So the title of my talk is Hypoglycemia, Making the Most of New Generation Insulin. These are my disclosures. And this is the agenda. I'm going to talk on the burden and impact of hypoglycemia briefly, talk about the history for the quest for the ideal basal insulin, and then discuss the two new generation basal insulin analogs. So on this slide, you see the results of the HAT trial. And it's always been a belief of some people that the risk of hypoglycemia in type 2 diabetes is considerably less than in type 1, and indeed isn't a problem. But this publication some years ago suggests that we have very much underestimated the risk of hypoglycemia. And in this study, which was a non-interventional global study which involved both retrospective and prospective collection of data, over 27,000 people participated, of whom nearly 20,000 had type 2 diabetes. Now, population studies have suggested that in type 1 diabetes, you can expect to, on average, have one severe hypoglycemic event per year, and that in type 2 diabetes, the risk is about 1/3. So that's 0.3 episodes per patient per year. But if you look at these slides and start on the left, you can see that episodes, total episodes, are happening very frequent according to these data, and those were collected retrospectively. If you look at the prospective data on the right and compare both retrospective collections and prospective, you can see that far from 0.3 episodes per patient per year, in this study, the frequency was 2.5 because prospective collection of data is much more reliable. So the burden of the frequency of hypoglycemia is great. And we also know that hypoglycemia can affect the body in many different ways. Of course, we all know that it causes cognitive dysfunction, coma, seizures, and if repeated, can impair the development in young people, young children. It can cause, of course, traffic accidents and even fractures if people have seizures. But if we look on the right, the real interest at the moment is whether hypoglycemia leads to an increased risk of cardiac arrhythmias and myocardial infarction and inflammatory changes within the circulation. And although the evidence hasn't yet to be proven, there is increasing data to suggest indeed that the severe hypoglycemia and possibly even less severe is opposing the beneficial effect of glucose control, explaining why in advanced ACCORD and VADT, we didn't see any benefit in cardiovascular disease from tight glucose control. Now, not only is hypoglycemia causing significant pathophysiological effects, but it has important influences on behavior. The slide on the left shows that from this study by Larry Leiter and colleagues from Canada showed that many patients, over 50% with type 2 diabetes and coming on for half of those with type 2, modify their insulin following a hypoglycemic event, not necessarily severe, although you can see the likelihood of change in behavior is greater. And if we look on the right, you can see that both primary care physicians and indeed more diabetes specialists would treat patients more aggressively if there was no concern about hypoglycemia. And in my view and the view of others, hypoglycemia is the main reason that our patients fail to achieve the glucose levels that we would wish for them. Finally, if we look at the health economic consequences, they are considerable. Just consider the direct costs of ambulance call out, extra physician visits, more frequent glucose monitoring and hospitalization. And then compare that with the indirect costs, if you like, they're the hidden part of the iceberg, because hypoglycemia will lead to absence of work, a less working capacity, and of course, accidents. So what can we do to try and reduce the burden of hypoglycemia? Now, for reasons of time, I can't discuss educational interventions or indeed the advance of technology. But my brief today is to look at whether new insulins can have significant benefit. So this timeline on here shows the isolation of insulin 100 years ago, the development of annual insulin preparations, the major advance of MPH in the 1930s in Denmark. And although that enabled treatment undoubtedly to be improved, hypoglycemia continued to be a burden with human insulin. Then the development of insulin detamir and insulin glargine in the 1990s, the first generation of basal insulin analogs, and you can see the half-life of these insulin was increasing. And then finally, the culmination of that with the ultra-long-acting basal insulins in the 2000s, insulin Glargine U300 and insulin Degludec, the first true once-a-day insulins. But just as important as the half-life is the variability, because you can see that if we measure air variability, and I'll show you how we might do that shortly, that the variability of MPH insulin is indeed high. There was significant improvement in insulin detamir and glargine. And finally, the new insulins, which offered the prospect of low variability. So why might glucose variability predict risk of hypoglycemia? So let's just take an imaginary patient. These are the fasting basal glucose. You can see the average around 7 millimoles per liter, 130 milligrams per deciliter. And the glucose is going up and down. But of course, this patient isn't at target. So if we persuade them to increase their insulin dose and enter target, the danger is that they will experience hypoglycemia. And indeed, that was certainly the case with MPH insulin. If we could use an insulin which had lower variability, then this might reduce the risk as shown in this diagram here. So there's this clear association between glycemic variability, hypoglycemia, and outcomes. And you can see there is also a line between glycemic variability and outcomes. And that reminds me to remind you that we clearly see that hypoglycemia has an influence on outcomes, as I've described already, including microvascular. And there's also emerging evidence suggests that glycemic variability independently of hypoglycemia may also have an effect, although I think it's fair to say that the main effect of glycemic variability is to increase the risk of hypoglycemia. So this lovely study from Tim Heiser and colleagues published in Diabetes shows you how the variability of these three generations of basal insulin has changed. So this was a study in individuals with type 1 diabetes. They were admitted to a clinical research center and they came up on 4 separate occasions and underwent a glucose clamp, a euglycemic clamp. You can see that some individuals received 4 injections of MPH insulin, others received Glargine U300, and some others received insulin detamir. So it is the first generation basal insulins. And the glucose infusion rates shown on the left are, of course, the amount of glucose needed to keep the glucose normal, in other words, reflecting the glucose lowering effect of insulin. And I think you can see that if we look at the intra-patient variability within these individuals, shown on the right and look at the insulin infusion, glucose infusion rate curves, you can see just how different these insulin are. These individuals are receiving MPH insulin. There's a peak glucose lowering effect in all, and you can see 2 of the 3 individuals are experiencing huge amounts in variability of the glucose lowering effect of the insulin. If we look at insulin Glargine U300, you can see that the variability is significantly reduced. There's still a peak, but nevertheless, the patients can have confidence that the insulin is going to do what it says on the tin. And if we look at insulin Detamir, you can see that variability is lower still, although we still see a peak. So that is the benefits of these first generations of insulin. And again, for reasons of time, I can't go through this, but there's clear trial evidence that that these insulins reduce hypoglycemia, particularly at night. And both Glargine U300 and insulin Levemir have similar benefits if we look at the overall trials. Let's look at the potential benefit of variability of the ultra-long acting. And here you see studies which again have been undertaken by Tim Heiser and his colleagues in Profil. And these experimental studies have looked at the day-to-day variability in glucose lowering effect for insulin Degludec versus Glargine U300 and U300. And on the bottom, you can see how the variability changes according to the time from the injection. So if we look at insulin Degludec in dark blue, you can see that there's a pretty consistent day-to-day variability as shown by coefficient of variation in areas under the curve of the glucose infusion rates. If we look at insulin Glargine U300 on the left, you can see that the variability is changing and it's at its greatest to 14 to 16 hours. And you'll also notice in this study that the variability in insulin Glargine U300 also is greater. So although it has a longer duration effect, in terms of variability, there doesn't seem to be a huge difference between the 2 preparations of insulin Glargine. Now that's all very well. I don't think my patients come to me and complain about glucose variability. What they want to know is what the clinical effects, and I'm sure the same goes for clinicians. But we should summarize by saying that there's 4 times lower day-to-day variability with insulin Degludec versus Glargine, and 4 times lower versus Glargine U300 with a lower potency, which is also relevant interpreting the trials. So let's start by looking at the insulin Degludec trial overview. These are some of the trials. Begin was the regulatory array of studies which were undertaken. Switch 2, just to remind you, was a crossover trial in individuals with type 2 diabetes who were prone to hypoglycemia, and DEVOTE was the cardiovascular outcome trial involving many thousands of patients. And again, both Switch 2 and DEVOTE and Begin were comparing insulin Degludec versus Glargine U300. Now, the first thing to note is that there was no difference in hemoglobin A1C, and by and large, that is because these were treat to targets. You'll remember that in these trials, attempts are made to keep the glucose, fasting glucose in particular, at comparable levels. So HbA1cs were different. If we look at fasting plasma glucose, there were modest reductions in fasting plasma glucose in all 3 of these trials. There was a reduction in Degludec dose in Begin and and switch 2, although an increase in devote, and that was just the observation. But I think what's important is consistently there were reductions in hypoglycemia in all 3 studies, and in switch 2, there was a trend towards reduction in severe hypoglycemia, and devote 3, that there was indeed a significant reduction in severe hypoglycemia. If we look at real-world data shown on this slide, studies from all over the world, most involving type 1 diabetes, but others involving type 2, showed a reduction in A1C of modest amounts by and large. Again, doses were variable, but a more consistent reduction in severe hypoglycemia, following a switch to insulin Degludec. And importantly, this is from a number of different insulins. These are not all compared with insulin Glargine U300. If we look at the Glargine U300 phase 3 type 2 diabetes trials, you can see that there were 3 trials involving type 2 diabetes, a basal bolus, a basal only, and an insulin naive. You can see that there was a reduction in HbA1c compared in U300 compared to U100. The comparator, importantly, is Glargine U100. You can see that there was a fasting plasma glucose reduction in edition 1, the basal bolus, and a slight, modest increase in the other 2 trials. And in terms of hypoglycemia, there was a significant reduction in both the basal only and insulin naive. So that is, if you like, a very brief summary of the clinical trial evidence. But what I think is more relevant and important is to look at the head-to-head trials. And what I'm going to do finally is to show you the 2 head-to-head trials which have been published to date. This is the BRIGHT study, and I'm going to spend a little time explaining the trial design, because many of you will be aware that the results are different between the 2 trials, and I hope to persuade you that certainly in part some of this is due to the way in which the trials were designed, and when you're interpreting the data and indeed making judgments about what insulins you might use in your clinical practice, it's very important to understand the data and then make your own one. So here's a study with insulin naive patients. It involved nearly 1,000 with type 2 diabetes. And as I've said, they're insulin naive. They had to have a duration of diabetes for over 12 months. And they could be using oral agents and GLP-1 receptor agonists at a stable dose for at least 3 months. And the A1C criteria and BMI are pretty standard. Patients were excluded, and this is important, if they were prone to hypoglycemia, if they had reduced awareness, repeated episodes of severe hypoglycemia, or end-stage renal disease. And you'll note there's a 12-week titration period, a 12-week maintenance period, and the patients were randomized after screening 1-to-1 to either insulin Degludec once a day or insulin Glargine U300 once a day. And that the starting doses were slightly different. Glargine U300, 0.2 units per kilo, and insulin Degludec, 10 units, with insulin administered in the evening and titrated at least weekly. So here are the results of the study in terms of hypoglycemia. I should emphasize that the primary endpoint in the BRIGHT study was hemoglobin A1C, and there was no statistical difference between the 2. They both showed improvement. But what is of interest, particularly in relation to this talk, are the rates of hypoglycemia. So these are confirmed hypoglycemia, both less than 3.9, less than 70 milligrams per deciliter, what we call level 1, and level 2, less than 3 or 54 milligrams per deciliter. And what you can see here is the titration period, the maintenance period, and the total treatment period. So these are not primary outcomes, they're secondary outcomes, but you can see that in the titration period, there was a reduction, a significant reduction in any episode of hypoglycemia, which was confirmed. And this was true both for any time and also at night for a glucose level below 70 milligrams per deciliter. During the maintenance period, you can see that the confidence intervals and indeed the point estimates, certainly for less than 70, are right on the line of unity, no difference. And if we combine the data, again, no difference altogether, although a trend towards benefit in less than 54, it doesn't reach statistical significance. So that are the break results. And finally, you'll note that there were few events with severe hypoglycemia to analyze. Now let's look at the conclude trial. This is again a little complicated, but the important differences are first that these were insulin experienced patients. Second, that this was, and therefore they were experienced, they had to be on basal insulin plus oral agents. They couldn't be pump users, they couldn't have impaired renal impairment, and the other important factor is these were patients who had at least one risk factor for hypoglycemia, be it impaired renal function, previous episodes of severe hypoglycemia, or reduced awareness. Again, this was an open label, treat to target trial. It was designed to be parallel one-to-one randomization. And it started off with a 16-week titration period and a 36-week maintenance period. And the trial duration was about a year. But some of you will be aware that early on in the study, it was discovered that hypoglycemia was happening frequently. And there was investigations, and they discovered that the glucose meter which was being used was reading falsely high, and there was significant severe events in both arms as far as people knew, because of course this was a randomized trial and the data hadn't been analyzed. But it was decided to change the meter and prolong the maintenance period. Importantly, the vast majority of patients agreed to participate in the study, but what it meant is that the maintenance period went on for significantly longer, closer to 2 years than 1 year. And I think it's important, again, to be aware of that. Also, the primary endpoint was hypoglycemia, not A1C, and it was defined as the number of severe or blood glucose confirmed, according to the NOVA classification at the time, less than 3.1, with a secondary outcomes listed here, the number of severe episodes, nocturnal severe, or basal insulin dosed at the end of the treatment period. Now, I haven't got time to present all the results in detail, but I just want to show you the results of the primary outcome and of the maintenance and total treatment periods. Please ignore this comment which says trend line error. That is indeed an error in preparing the slide. What I want you to look at in this forest plot is the primary endpoint. So it was maintenance, symptomatic overall episodes confirmed during the maintenance period. And you can see that although the point estimate shows a 12% reduction, the confidence interval clearly crosses the line of unity. And so this is not significant, p-value 0.17. Now, number of statisticians would say at this point, you have to stop. You can't analyze any other of the data. Whereas other statisticians would say, well, actually, you could look at the other endpoints, which have been predefined, but because the primary endpoint is not significant, these become exploratory, if you like, hypothesis generating. And I think it's really important to understand that. But I think it then gives us the advantage of looking at the data and allowing us as clinicians to make up our mind. And you can see that if we look at the maintenance period or the total treatment period for nocturnal symptomatic confirmed and severe in particular, both maintenance and during the total treatment period, you can see that there were reductions which reached statistical significance, although I want to emphasize again that these have to be regarded as exploratory. And actually, just going back, if you want to think about that, these are the numbers needed to treat to prevent one episode, 3 and 26. So in summary then, what are the important differences between these two trials? Because I think it really is important in helping us to decide what insulins we might choose during in clinical practice, as I've said. So I think the important ones are the patient population, as I've explained, insulin experienced versus insulin naive. That in conclude, these were patients with were at risk of hypoglycemia in BRIGHT. They were excluded. I should also say that in conclude that the basal insulin could be randomized to morning or evening, although that didn't make any difference to the results, which why I've not presented. In BRIGHT, insulin was dosed in the evening, and the target plasma glucose for titration, you can see, was a little bit different, a bit higher in BRIGHT compared to conclude, with, as I pointed out, changes in the two endpoints. So if we look at the totality of evidence and considered insulin Degludec, I think that it is pretty consistent in terms of its effects in hypoglycemia, and that's something that you may want to consider when deciding which of these insulins that you use. But I want to focus on the overall summary. I think it's true that both newer basal generation insulins like Degludec and Glargine have led to an improvement in PK and PD properties compared with previous basal insulin. I think the data on insulin Degludec have shown a consistent reduction in hypoglycemia, including severe episodes, compared with various comparators. And I think it's also true that reduced risk of severe hypoglycemia with these insulins may help to reduce the burden of hypoglycemia for patients, physicians, and overall on society. But I think it's for us as clinicians to weigh up the data before deciding which of these insulins we should use in clinical practice. And with that, I want to thank you for